You're in a busy ED. A patient in severe sepsis lies in your resus bay. He's on pressors, he's gotten fluid, but remains hypotensive and is now somnolent. O2 saturations are falling, so you pull the trigger. You're gonna intubate.
Can we drop 200 of ketamine and 100 of rocuronium?
Drugs are in, doctor.
All right, let's take a look here. I see epiglottis, I see cords, tube is in.
You confirm placement, place the patient on a vent, you realize you potentially just saved this patient's life, and Queen starts playing in your head. You walk out of the resus bay to see your next patient, but you're forgetting something important. Post-intubation analgesia and sedation is a cornerstone of ED management, and optimized post-intubation care has been shown to decrease mortality and morbidity in the critically ill. Therefore, over the next 30 minutes, with the assistance of Cook County Clinical PharmD Joanne Witzel, we will outline a new ED-focused protocol for optimized post-intubation analgesia and sedation care.
Management of the intubated patient in the emergency department. This is probably one of my favorite topics to talk about with ED practitioners, since it's probably the most neglected in regards to patient care of ED practitioners. So let's begin. My name is Joanne Witzel, and I'm the Clinical PharmD for the Department of Emergency Medicine Toxicology at Cook County Hospital. And I'm here today to give you a short topic discussion of how to properly manage the intubated patient in our emergency department. So first, let's go over the objectives. Quite simple, there's two. First, let's describe the rationale for post-intubation analgesia and sedation. And second, to compare and contrast the various analgesic and sedatives used here at our institution. Unfortunately, by no means is this a comprehensive review of all the potential agents that you can use. We can only focus on the ones that we use here at Cook County Hospital. So let's first discuss some important concepts in regards to intubation. First, events prior to intubation can be very painful for a patient. And think about it, intubation itself is very painful. Think of a large, hard plastic tube being placed down your throat. I can't imagine anyone feeling comfortable after that. Procedures done after intubation are often painful for the patient. For example, you may be establishing central lines, getting them to the CT scanner, you may have to restrain them, etc., etc. Right now, there's this focus, or has traditionally been our focus, is to provide deep sedation. But what studies are finding is deep sedation is associated with poor clinical outcomes. So for example, it ends up providing a longer duration of mechanical ventilation for patients, longer ICU stays, can result in organ system failure, worsening delirium, and higher reintubation rates, which is not good for any patient. So the main concept today in regards to post-intubation care is we're really going to focus on analgesia as the cornerstone of post-intubation care, where there's this emphasis now on a lighter level of sedation, unless of course it's contradicted. So for example, you may have to consider deeper sedation for cases of substance withdrawal, patients who are having status epilepticus, severe asthmatics, intracranial lesions or bleeding, or a need for continued paralysis. So let's take a look at the negative effects of poor pain control. So patients who recalled pain during their hospital experience had higher reports of chronic pain, post-traumatic stress disorder symptoms, lower quality of life. They have found that poor pain control leads to increase in catecholamine that impairs tissue perfusion, and poor pain control results in negative effects on the immune system. So let's take a look at what the current ED practices are for post-intubation care around the country. In a retrospective cohort study by Bonomo et al., they actually looked at 117 patients, and what they wanted to take a look is they hypothesized that in the ED, intubations would receive inadequate post-intubation anxiolysis and analgesia after RSI. And what they found in their study of 117 patients is that 33% received no anxiolysis, 53% received no analgesia, and actually 20% received neither agent. And that's not really good if you really think about it from a patient perspective, or as a family member watching that. In another study by Weingart, and it was another retrospective cohort study analyzing the data that they found on a national survey database looking at intubated patients, ED patients, and what they found, and they had a patient population of approximately a little over 1 million, and what they found is less than half the patients received either some type of sedative and or analgesia. Again, not really good numbers from our perspective in providing care for our patients. If we look at another retrospective cohort study that looked at the time of delivery of sedative when practitioners used different paralytic agents during their RSI procedure, what they found is that there was a greater time lapse in providing sedation in patients that received rocuronium compared to succinylcholine. And again, this probably is because rocuronium has a longer duration. So practitioners a lot of times, because the patient's not moving or thrashing, are lulled in this false sense of security. Oh, well, the patient must be comfortable. That's not true. The patient is fully aware of their surroundings. They just can't do anything about it. And that holds true for our department also. Most of the time, once the attractiveness of the procedure of the intubation itself is over, a lot of practitioners just walk away. And it really isn't until the nurse taps you on the shoulder and says, hey, your patient is bucking the vent or has self-extubated yourself, do you kind of realize that you need to provide post-intubation care. So this leads us into why we have decided to implement an emergency department analgesia and sedation protocol for mechanically ventilated patients in the ED. And this is just a quick slide showing you what our protocol is going to look like. So the whole goal of our protocol is basically to promote better pain control. And this really is the emphasis nowadays in current trends in the ICU and in the EDs, is really give your patient good pain control. And there's an emphasis on frequent initial bolusing. And then once you're at goal, you can rebolus the patient every 2 hours as needed. And unfortunately, if you find that you're giving your boluses more frequently than 2 hours, at that point you can start a continuous infusion. At least here at our institution, that's what we're promoting. Next is to provide light sedation, and this you can do through PRN bolus dosing, because you really want to avoid the pitfall of over-sedating the patient by just putting them on a drip. Why this whole bolus emphasis? Well, because a lot of times titrating a drip without a bolus leads to much slower resolution of agitation. Think about it. What happens is, instead of providing boluses for your patients, most of the time people will just go in and say, okay, increase the drip by this, increase the drip by this, increase the drip by this. And then eventually, once the drug catches up and you get the stacking effect, and sort of the peak effect of the drug, what happens is you get this oversedation of the patient and an adverse drug reaction. And then everyone panics. Then that's when they discontinue the drip because, say, for example, the patient becomes hypotensive. And then what happens is then they leave the patient alone, the drip is off, it starts to wear off, and then it promotes this acute agitation again within the patient. So points to consider when you're selecting your drugs during the post-intubation period. First, your preferred agents should be drugs that have a very rapid onset. Next, they should have a very short duration of action. And then finally, minimal adverse drug reactions. Again, I would love it if we had a perfect drug that basically hits all three of these points. But unfortunately, you're going to have to pick and choose what you're willing to live with. Your first line in post-intubation is to provide adequate pain relief with analgesic. Before you even walk away from the patient, make sure you tell your nursing staff what analgesic you want to use on your patient. And this is going to hold true for most of your patient population. There really isn't anyone that you want to avoid analgesia in when they're intubated. And also, by using analgesics, this allows for lower doses of sedatives to be used. It almost acts like a sparing effect. I mean, if you think about it, if you use lower doses of two agents, it gives you less chance of having an adverse drug reaction, and it's much better for the patient. Second line, if the patient remains agitated or anxious, then you want to consider giving them a sedative at that point. And most sedative agents obviously have sedative properties. They have hypnotic properties, anxiolytic, amnesic, and anticonvulsant properties. However, all of them except one, have no analgesic properties. So that's why if you just give a sedative and you think, oh, the patient's covered, again, you're not addressing the patient's pain. And that's really what we're trying to focus on, or there's this shift in where you really need to address the patient's pain first, then provide the sedation. So let's take a look at the analgesics. Here at our institution, we have to deal with morphine and fentanyl. Those are our two agents of choice. So let's compare and contrast them. Onset to peak effect. Unfortunately, morphine has a little bit longer of a delay in its peak effect of 20 to 30 minutes, where fentanyl peaks within 2 to 5 minutes. Duration, morphine can last 3 to 4 hours, which can be nice, and fentanyl anywhere from 30 minutes to 2 hours. With morphine, you can give the bolus dosing of 2 to 6 milligrams IV push every 10 minutes until you're at goal, and if need be, start an infusion. With fentanyl, you can give bolus IV pushes of 25 to 100 micrograms every 10 minutes again until goal. Again, we're emphasizing having to assess your patient every 10 minutes and providing them with a bolus of analgesic if needed. And if you can't control them with IV pushes, you can also, with fentanyl, start an infusion. Morphine is the preferred analgesic for a patient who's hemodynamically stable, but most will probably end up needing fentanyl because it's the analgesic of choice for a patient who's hemodynamically unstable. Things you should consider from an adverse drug reaction with morphine is hypotension, which is related to a histamine release, and itching, again, related to the histamine release of morphine. And unfortunately, because it has active metabolites, it can accumulate over time in patients with renal hepatic failure. In comparison to fentanyl, the adverse drug reactions you have to worry about is this chest wall rigidity. And this is seen usually if you're going to give someone a really large dose, say for example 200 micrograms, or if it's given too rapidly. So make sure you instruct your nursing staff to give it a little bit slow IV push. Bradycardia is also present or can be seen with fentanyl, and again hypotension but less than morphine because it does not have the histamine release. And unfortunately it too can also accumulate in patients with hepatic failure. So let's take a look at our sedatives that we use here in our ED, midazolam and propofol. Onset to peak effect for midazolam, which is it's quite nice, it's 5 to 10 minutes, where propofol of course is better, it's within 2 minutes. Duration with midazolam of action is 1 to 2 hours, with propofol less than 20 minutes. With midazolam, you can bolus 2 to 5 milligrams IV push and start an infusion if need be, if deeper sedation is required or the patient remains agitated. With propofol, you really want to avoid bolus dosing because this is usually what causes the profound hypotension. However, if you need to provide a little bit of a bolus, you should really try to limit that dose up to 20 milligrams. And then, of course, you start an infusion. This is how the drug is given. Start between 5 mics per kg per minute up to 80, and you can titrate it every 5 to 10 minutes. Use. Midazolam, it's preferred in patients who are hemodynamically unstable, and propofol is sort of your drug of choice for patients who are hemodynamically stable, especially their blood pressure. It's also the drug of choice for patients who have CNS injury, seizures, frequent neurochecks, or are going to be intubated for a period of less than 72 hours. Things to watch out for from an adverse drug reaction for midazolam is tachyphylaxis, hypotension, and unfortunately it does accumulate in renal failure. And with propofol, you have, of course, hypotension and also dose and rate related hypotension and bradycardia. And there is literature that says you should avoid propofol in patients who have egg and soy allergies. So let's take a look at monitoring. From a gold standard, of course, it would be great to talk to the patient. Not feasible. Vital signs should never be used alone, but if you do notice your patient remains tachycardic and hypertensive, this should serve as a cue for further assessment. Behavioral scales, numeric pain rating scales, is most commonly used in the ICUs for pain assessment. However, this may not be feasible in the ED. So what we've chosen for our protocol is you use the Richmond Agitation Sedation Scale, the RAS scale. This is a tool used for assessing ventilated patients' arousability. It is the most valid and reliable sedation tool for measuring quality and depth of sedation in the adult ICU patient population. Here in our protocol, we're saying that you should do this and assess your patient every 15 minutes. And your goal is to keep them between 0 to -3. Now, this may sound like a lot of work, but if you look at the description of what 0 to -3 is, you're pretty much doing this anyways. This is how you're assessing your patient. So now realistically, all you're really doing is just documenting it now. And again, this is something that you're doing. Now it's just requiring you to document what your assessment of the patient is. So that's really the end of today's topic discussion on management of the post-intubated patient in the adult emergency department. So just to quickly summarize, good post-intubation care is associated with better patient outcomes, which is really what we want. We want to take care of our patients' needs. The current emphasis on analgesia-based sedation protocol, that's what we're trying to do. Emphasize, control your patient's pain first, and then provide light sedation. And we're moving away from this traditional thinking of having this deep hypnotic-based sedation. Your primary approach is to provide bolus dosing for pain, followed by continuous fusion when needed, and then to provide light sedation with PRN doses of sedatives, unless, of course, deep sedation is required. Thank you for listening today, and have a great day.
All right, you're back in the ED and you just intubated your patient.
Okay, let's give some immediate analgesia. His MAPs are 60, 65, so let's go with 100 micrograms of fentanyl because it's shorter acting and shouldn't cause as much hypotension. If his pressures were better, I would have used morphine.
15 minutes pass and the nurse alerts you that the patient remains agitated.
Let's redose the fentanyl and now give a sedative. I'm going to keep rechecking the RAS every 15 minutes, redosing as necessary, and shoot for a RAS score of 0 to -2.
This is good post-intubation analgesia and sedation care. The protocol discussed in this webcast can be found on the ED Policies and Guidelines intranet page. Thank you to Dr. Joanne Witzel, Dr. John Balitz, Dr. Scott Bonanno, and Dr. John Cook for the creation and implementation of this protocol. I'm John Hardwick, and remember, after you've placed the tube, the job is not done. Good post-intubation care saves lives.